The last sort of formal presentation panel discussion we're going to have of the 2012 Symposium is upon us at the moment now. And so we have an esteemed panel of participants and responders to address this critical topic, and we're making the transition from a lot of the as-is, to-be thought, ideation, warming up to, as I said, the next session will be about what are the specific recommendations, both short-term and long-term, to help move this vision forward in very pragmatic ways. But on the way to that, this session is, as we've called it, building cross-system information sharing from the ground up, and using electronic health record technology to create virtual records for targeted populations. So we're trying to bridge two worlds, which is to look at, on a large scale, what the infrastructure that is in place or being put into place that we can use to accomplish long-term goals here. We're not there all the way yet, but we're on the way. And so we need to be knowing what the future is in order to be able to build today solutions that can address today's needs, but also have the future in mind. And as we've said for all the other panels, we're not going to read the bios. You have them all in your packets there. But we are delighted and privileged to have Jessica Kahn, the Senior Technical Advisor from CMS, to work with us here and to help both provide some commentary at the federal level and also help moderate the panel. We have a number of folks who will be presenting this morning. Dr. Lynette Scott, who's the interim, well, that's wrong there. She's the Chief Medical Director now at the California Health Services. A new role for her, and we're delighted that she's here. Presiding Judge Mike Nash from Los Angeles County will provide also perspective from a small jurisdiction in California about the complexity of information sharing. We'll follow up with that with Kevin Gaines from the Department of Social Services in California, and then we'll have some responder commentary from Dr. Harold Lehmann from Johns Hopkins School of Medicine, and also Nick Macchione from San Diego County. And so with that, let me turn it over to Jessica.
Hello. Oh, I don't even have to really project. This is nice. Usually I have to be right here. I'm Jess Khan from CMS. I wish I could have been here all 3 days because I'm sure many of the things that I wanted to talk about have actually come up. So forgive me, first of all, if I'm saying things that you all have already discussed or wanted to hear more about. So I'm going to go through my comments very quickly because this is really the meat of the presentation. So Daniel had asked me to focus on 3 things in particular with my 15 minutes. And one was promising developments about innovative IT projects that I know about from the CMS side, the building of this information technology highway, and the importance and trajectory of interoperability in health and with human services and public health and so forth. So because it has EHR in the title, I am behooved, even though it's no longer my bailiwick, to talk about the Medicaid EHR Incentive Program and the Medicare EHR Incentive Program, which, as you probably have heard me say sometimes, that's the other M in CMS is Medicare. We let them have a little glory once in a while, but we all know that Medicaid's the best. So yesterday, CMS actually announced that we have reached a milestone that we had set for the entire calendar year of 2012, which was for 100,000 providers to receive an EHR Incentive Program payment. And we've reached it already by June. We are already at 110,000 providers paid to date. So that's pretty amazing. That's 48% of all the eligible hospitals, which includes hospitals of all sizes, critical access hospitals, small rural hospitals. 1 in 5 of the eligible professionals for either program has received an incentive payment. Again, this is very, very, very critical when we're thinking about the infrastructure that we're talking about for this general community. That's $5.7 billion. This is Recovery Act money, so that's the good news. $5.7 billion has gone out into the clinical community to support electronic health record adoption. And more than $3 billion of that for Medicare just in 1 year, from May to May. And almost $3 billion of that from Medicaid from January 2011 until May. And so the states really take credit for that. There are 44 states that have their EHR incentive programs up and running, and all of them are making payments. Yes, there are a few that still haven't launched their programs yet, but they are planning to do so in 2012. So considering all the other things they have on their budgets, all the news that we hear, everything that you know better than I is a crisis in the Medicaid budget. The fact that this many states have prioritized health IT and EHRs and launched these programs and see this as the foundation for a lot of their other service delivery work is pretty important. So I just wanted to note that because I think that's pretty exciting. The other thing I wanted to note about the EHR incentive program before I move on to some other topics is we actually have now 6 states that have also asked for funding. Lynette and I were chatting about this a little bit, asked for funding to support health information exchange, I'm sorry. So it's not just the EHR incentive program, it's this infrastructure, this highway that you were talking about moving this information on. So Medicaid has actually contributed to that infrastructure build in 6 states, and we have a number of others that we're talking to in the planning. But we're talking about sitting down with private payers, with public health, with large provider groups, and investing in this kind of infrastructure so that there's trusted exchange, so that it's built out statewide, not just in pockets with no white space, and that there are rules of the road for what that will look like, and it'll benefit the Medicaid enterprise as a whole and its human services and public health partners. So we're very excited about that. Those states are Iowa, just recently this week, Alabama, Arizona, Massachusetts, Vermont, North Carolina, and Tennessee. So kudos to them. Again, they went beyond just what was necessary to implement this program and have taken it to another level where they want to contribute their 10% match towards this information technology highway. So about promising developments, there's actually some really good stuff. I'm reminded as I'm talking about this subject that technology is really less of a barrier these days for health information exchange to happen. It's really the barriers are things that you've talked about already this week, which are around policies. There's that little money piece too, but policies is really the primary barrier. So one of the things I wanted to focus when I talk about innovative IT projects is a little bit of both, not just the innovative ones on the technology side, but the innovative ones on the policy side, and that's what this panel is really going to talk about. So the first one I wanted to mention is related to the exchange marketplace. And that's a project called Enroll UX 2014, which was a partnership with 17 states, 8 nonprofits, and the California Healthcare Foundation. And they got together to create it's a public-private partnership to create an online platform for enrolling in affordable healthcare insurance so that everybody doesn't have to figure out the same thing over and over and over again. They said, let's get it together. Let's think about what the consumer experience is going to be. How seamless should it be? It should be the Amazon.com, or in my life, it's usually diapers.com experience. And let's set that up so that it's that easy. I mean, I know just even as a federal employee that it takes me concentrated time to go through open enrollment every year and figure out what's changing and who's in my provider's network and has that happened and what happened with this and that, and now they've changed. I can't get the 90-day drug sent to me. I mean, it's a hot mess. So this is not what we want to do for the insurance marketplace. So to have this concerted effort where you had multiple different entities weighing in on that means that anybody else can now take it and use it. So it saves time and money. The other one is something that we call the Top Coder Challenge. So this is where we looked to the people who do this in their garage for fun to think about how to streamline provider enrollment, to create software that would then be available in open source to anyone. This is a partnership with NASA, of all people, and Harvard, and the state of Minnesota. And there's prize money. So these guys are out there. These are a series of 150 challenges to create very specific code and very specific software that Medicaid or anyone else could use to help with provider enrollment. And so we've talked a lot about, states being innovative and states working together. And so this was an opportunity to put some money out in the private sector to say, hey, you guys who are making those fabulous smartphones or whatever other technology you're doing, how about applying that to the healthcare space, and particularly to the provider enrollment space. So that's pretty exciting. And then I wanted to draw everyone's attention to a new report from HIMSS, which is it was written from the State Advisory Panel perspective about transforming healthcare through health IT and health information exchange. Very strong emphasis on patient participation and health literacy, which I think are really key. You can't build this information highway and put all the data out there if nobody knows how to use it, how to consume it, what does it mean. So it was very important, I thought, that came out of the states, recognizing that their pathway to transformation had to come with that patient focus. So let's talk really quick about the trajectory, shall we say, of health information exchange. So, and Rick will back me up on this. If you'd asked me 2 years ago what I thought was the foundation to health information exchange, I would have said meaningful use, right? Am I lying? Yeah. Sort of out there on the proselytizing meaningful use thing for 2 years. I admit it. I feel like I'm at an AA meeting. But guess what? The pathway to health information exchange is no longer about meaningful use or about electronic health records. It's about healthcare transformation. It's about ACOs. It's about care coordination and all of these things that have really nothing to do with meaningful use. Meaningful use gets us to a certain playing field, level playing field, and gives some money on the table, or penalties if you're Medicare. But what really is going to keep it on everybody's radar is going to be care coordination. And they could even change their name, this HIMSS report said, to Healthcare Coordination Facilitation, which I think is a little lengthy compared to HIE, but whatever. They didn't ask me my opinion on acronyms. And actually, I also think that's a little short-sighted because it's not just care coordination, but it's also some of the things that we've talked about, which is really moving data for administrative decision-making, not just for clinical decision-making. So some of the use cases I thought I would bring up to you that I thought are interesting don't get as much airtime as the unconscious guy in the ER who shows up and you don't want to give him a certain drug because that'll kill him, and you only know that because of health information exchange. I mean, that's great, but there are some use cases that really should matter to us also. And those are things like non-medical case management we've talked about this week with Department of Justice, child welfare, foster care. That data can move electronically outside of an EHR or with an EHR. So we're sort of seeing these parallel now, not necessarily dependent on each other. Secure messaging with local health departments and children with special health care needs providers. Public health notifications to hospitals around outbreaks. The whole medical home, behavioral health home, accountable care organization, all of it is dependent on this information moving. Nobody's going to see shared savings or improved care coordination unless that information moves. It can move through an electronic health record, and that's the ideal, but it doesn't have to. We don't have to wait until 100% of this country's providers have an electronic health record. Health information exchange can move in incremental steps also. Transitions of care, notifications to disease management providers, and even things that matter to payers, like when we request additional clinical information so we can pay a claim, that could be sent to us through the health information exchange in secure messaging, as opposed to scanning and sending, or, God forbid, snail mailing us clinical charts. So there's a lot out there, and I think this is actually not, it's not a hard case to make. I read last week that 85% of healthcare executives think that the pathway to sustainable HIEs are ACOs, not meaningful use. I don't say that back at CMS to the high-tech team. You know, I don't want to take the wind out of their sails, but because they got to get all 50 states up and running, they got to get all that money out the door, and we want everybody to do it, and this is certainly the carrot to do it. But health information exchange and electronic health records can have different pathways, and so that's, I guess, what I wanted to say most importantly out of everything I'm going to say today is don't think of them as interdependent, because if you do, then you're sort of waiting for their shoe to drop around electronic health records. Electronic health records for the EHR incentive program have to be certified, and all the focus is on who are eligible professionals. So does that include behavioral health or mid-levels? No. Does that include nursing home facilities, home health? No. Hospice? No. Nurses? No. Caseworkers, case managers, social workers? No. So if we only are focusing on this program, we're not going to get to where you all want to go. So we need to think about electronic health records as a tool, very important, not dissonant, but we also need to think about health information exchange in that clinical highway, even administrative data highway happening on a parallel track. So the other piece that I would say about sort of the trajectory of interoperability here is then that broadens the funding stream available. If we were only thinking about it in terms of the clinical piece and around meaningful use, then there's some limited pots of money from the federal government for that. But if we're thinking about this as how Medicaid or other payers, Medicare, food stamps, SNAP, this is part of how we do our business and how we administer our programs. So now we're talking about funding streams that are more commonplace. These aren't just sort of the one thing attached to an act, and it's only available until this date, and then it expires. Now we're saying, think about how you do program integrity Medicaid. Think about how you move the data back and forth for some of the things that everyone agrees are essential to your program, and think about how to digitize those and move those through health information exchange, health data, health information exchange, and not just thinking about it for the purposes of meaningful use. So it sort of opens it up a little bit, we think, about how you're doing business. So if you're the state of Oregon, anyone here from Oregon? Oregon, state of Oregon, behemoth service delivery reform happening in Medicaid now, right? Is it going to work without health information exchange? Oh, heck no. So, and it's not happening around health information exchange. The state of Oregon didn't knock on the health IT people's door at CMS and say, we want health IT. The state of Oregon knocked on CMS's door and said, we want improved care, better care, lower costs. And oh, by the way, that infrastructure has to do with health information technology moving and enterprise-wide, not just thinking about from Medicaid, but where the patients come and how they intersect. So don't always look for the front door. What we're saying now is we're seeing many different ways to do it. We're getting waivers from states and from hospitals that want to address this. It's coming at us all over the place. It used to just be one little team that Rick was running, and now it's all over the agency. And that's good news. It's kind of hard for us in terms of coordination, but it's really good news in terms of funding at the state and local level. So with my last minute, 57 seconds. Boy, that's a little crazy, huh? It's fast. I'm really excited about the particular use cases that you'll hear today because I do think it takes it out of the primary care paradigm for health information technology and for electronic health records. And so I encourage you to think about that and follow up with us, with CMS, or any of the partners if you have questions. We really want to see what comes out of these 3 days and sit back down to think about what our role can be in enabling any of the things you've set as priorities. And we're very excited to do that with our other federal partners, even trying to tackle poor Amy, the whole IRS issue, which I'm not going to talk about. Okay, thank you.
So it's a real pleasure to be here, and actually I got approval to travel last Thursday afternoon, so I was really excited to be able to be here and be part of this panel. And as Jessica mentioned, so my name's Lynette Scott. I've actually been in the public health side for the last 7 years and had the chance to work as the interim deputy secretary for health IT, so coordinating our high-tech work in California for about a year. But just in the last week have made a job change, and it's actually a new position. So it will unfold as we go, but it's the Chief Medical Information Officer. So it's bringing that medical informatics to the Medicaid program to help think about things from a policy perspective and how we use data and information more effectively. And the details will unfold. But today I wanted to highlight some of the things I think that have been talked about over the last few days, and it's, Jess and I didn't talk as much beforehand, but we might have, in terms of thinking about the HITECH Act. And one of the things, as being an HIT coordinator and working in that area, we talk about meaningful use and EHR adoption and HIE and all of those kinds of things. And so the HITECH Act, it came into place 2009, turned our worlds upside down. We got very focused around it. And it really, though, did start to lay the base. And that's what it's meant. And it also, I think it's really important to think of it in terms of being an incentive program. It is part of ARA, American Recovery and Reinvestment Act. So it was meant to be time limited. It was never meant to pay for the whole thing. It was never meant to do the whole job. But it was meant to kick things off. And so whenever I talk about it, though, I try to focus in first on the priorities of the Meaningful Use program. The Meaningful Use is one of those things that we focus on when we're administering a program, because you have to check the boxes so you can get the money, right? And there's been lots of discussion, as Jess said, about, well, what's the value of this? Where is it really going to get us? But as she said, it's laying the groundwork. You can't start to move data until you have structured data. So it really did start to get us focused around what that meant. But the priorities and the reason we're doing that is because we want to improve quality, safety, efficiency, and reduce health disparities. And so certainly coming from a public health background, our role there has been really looking at health disparity, health equity, and how do we change that equation. Engaging patients and families in their health care. And this is one that didn't get as much emphasis early on, but is much more so now, recognizing that the driver is when we as a patient or as a family member need to take care of and get medical care. How do we help engage in that? And understanding that that's a huge driver for the marketplace and for the way we deliver services. Improving care coordination, and this one too, relatively light and meaningful use stage 1. But again, you have to have structured data before you can move it, and then once you start to move it, then you can really do care coordination, which is where the drivers will be in the long term. Improving population and public health, of course, from the public health side, I latched right onto this one. But even there, it has been a challenge because the funding stream didn't really designate much for public health, and so there's a requirement providers to get money have to send it in this format. Well, public health didn't quite get the resources or the timeline to receive it in that format, so we've been scrambling and struggling ever since this came out, and are at different levels of readiness and working through that. And one of the aspects from the California side in particular, with our size, we have 10 regional immunization registries of 61 local health jurisdictions that are independently appointed health officers by their local board of supervisors. So it's very much a federated kind of environment, and getting ready for receiving this has been a challenge as well, just in terms of the complexity and geographic variation in the way healthcare is delivered, and so how that impacts public health reporting. And then the underpinning, ensuring adequate privacy and security protections for personal health information. Many of us have talked about this as being the showstopper. If we don't get this done, nothing else matters. The technology really is there. Yes, the subtleties of the technology to make sure it meets the business need is being developed, and that's where the meaningful use requirements are coming into play. But the showstopper is this one. So lots of activity on this, both at the state and federal level, because that really does lay the groundwork for how we can move data. So HITECH has 3 stages, meaningful use stage 1, 2, and 3. 1 is what we're implementing, 2 is being finalized, and 3 is being discussed. So this is where, though, I've really tried to encourage folks to think about, especially from the human services side and that care coordination perspective, what are the requirements that an EHR should have to be able to actually do this kind of care coordination, send the right information to the judge to be able to make decisions about the foster child psychotropic medications. What is it that needs to do? In order to get the technology to have the capability, we need to be talking about those stage 3 meaningful use requirements right now so they get written into it. The other aspect of this that I think from a system perspective is that HITECH really is introducing a norm change. So again, from a public health perspective, a lot of the work we do is how do we change the norm? So how do you go from the norm of where smoking is acceptable and this room would have been filled with smoke maybe 40 years ago to it being smoke-free, and the impact that has on our health? So what is the norm change that we're trying to do? And HITECH really is triggering a norm change, taking us from this paper environment to an electronic environment. And all of us that have worked in different systems and government, we've been through these different automation processes. If all you do is take the paper and make it electronic, you have the same process. You don't leverage what you really get from an electronic system. And it often takes implementing, using it, and then figuring out that, oh, I really can change my business process, and I get lots more efficiency out of this technology than I originally thought I would. So that kind of transformation is very normative changing, and it is shifting. And we're seeing that and hearing the stories as folks are going through training. The folks that are going through training now through medical school, they're in their universities, they're in the facilities that have EHRs. There are folks that are graduating from medical school now and nursing school and others that have never touched a paper record. So they will demand a place to work that does not have paper. And that's a true norm change. So Is it happening? It's definitely happening. I mean, Jess gave the numbers overall, which are really huge. For a California presentation, I picked out these 2 particular points in time to help show it graphically. This is the November money out the door to hospitals and providers by state, and it was $1.2 billion then. And as of March, and this is later data than she shared, is $5.03 billion out the door. But you can see the green's gotten brighter. The other thing that you may not notice unless you look really closely is the scale changed. So to be dark green in November, you had to have $75 million out the door in your state, Medicaid and Medicare combined. Now it's $151 million. So the scale changed in addition to the fact that the colors changed. So absolutely, the norm change is occurring. So what that really does is it challenges us to think about, well, what does this mean? What are the systems we should be building or have if an EHR is the norm as the base for clinical operations? And so this got me thinking. I added the title yesterday after the presentation, Systems of Systems, so that might look familiar. So really an EHR is a system. It's even a system of systems. But then you start talking about exchanging data and an HIE, HIO, HISP, whatever it is we're calling it today. That's another system, and how those interact between the local and the state and the federal, and then between our different agencies. It really is a huge system of system. And so the standards and how that gets used and built is really critical. And the unfortunate side is we're building all those as we do it. So yes, we are investing money that we're probably going to have to reinvest as the standards stabilize. On the other hand, it's so complex that I'm not sure we could have done it otherwise. So it is a really fine balance, and we're all living that tension of how fast to push versus how much stability is there to do it. And so we're very grateful for the many folks that are helping with those standards. And so when we think of the norm change, the EHR incentive program is starting this process, but it's really the payment models that are being tested through CMS, the different changes in the delivery system, not the technology, but the system, that are really driving this. So accountable care organizations, dual eligible pilots, delivery system reform, incentive payments, the new lingo I'm learning in the last week. Getting there. But the other thing that I wanted to highlight briefly is the National Quality Strategy and National Prevention Strategy. And so again, thinking from that destination, why are we doing this? Why does it matter? These pieces have been in place. So they've been published over the last year. They were instigated, I think, by the Affordable Care Act. But it really is highlighting it. So within our states, we are using these as templates to say, what is it we need to do to make our state healthier? And so we're looking to these guidance. So the National Quality Strategy, key points: better care, healthy people, healthy communities, and affordable care. So you hear this theme over and over again, and you see it reflected in the National Prevention Strategy as well, and these are just highlights, and I have the links there if you want more information. So strategic directions are the foundation of all prevention efforts: healthy and safe community environments. That goes well beyond the doctor's office. The doctor's office is probably less than 5% of the impact on your health. Probably, and I'm guesstimating numbers, so don't quote them, but 90 to 95% probably is really what happens outside of the healthcare delivery system that impacts your health, your ability to walk safely outside, for the kids to play, to get education. Lots of literature, the best form of birth control is education. So it's what happens elsewhere that really drives health. And so health and safe community environments, clinical and community preventive services, empowered people, elimination of health disparities. So you're hearing the themes. I mean, we know this is why we're here. This is why we're in government. This is, I mean, being a government person, and why I'm not in the private sector, because this is what I believe in, and I want to change this infrastructure. So, and then there's some specific things that have been highlighted. And of course, this echoes the idea of the triple aim that we've been hearing about for much longer than those, which really drives these connections again. So just briefly, in terms of some of how we've been looking at this in California, all of this gets internalized in each of our states. Within our Health and Human Service Agency, we've had a HIE Policy and Coordination Committee to try to help draw connections, because when high-tech came out, it said meaningful use. Well, the Medicaid program got it, the public health program got it, and everybody else sort of said, well, what's this have to do with me? And so we convened this and ended up actually identifying 3 use cases so that we could have the conversation. What would it mean if the EHR is the norm? how does this completely change the way we deliver state services if that's the norm? Instead of having to have case reviews where you go and pull the paper records if it could be sent to you. What does that mean? Staffing, training, huge. So we, over the last few years, developed some goals to try to really focus in, and of course, with our other duties as required kind of efforts, but how do we leverage these other funding streams to do this? So the right access to the right information at the right time, looking at how we're exchanging information between departments, which I think is echoing what we're hearing at the federal level too. Get your act together and talk to each other, or we're not going to fund you. So I heard that message. Implementing it's going to be a whole other challenge, right? And then engaging consumers and their providers. And another aspect of the high-tech goal that we keyed in on, our high-tech experience, our HIE cooperative agreement last year, it's been a year now, we had our site visit, our first site visit, and one of the things that we were asked to do, though, after that was within 30 days come up with a breakthrough goal that represents bold, audacious statements of achievement around which your state and its leaders can strive beyond the state HIE cooperative agreement program period. So I have to quote that because I didn't come up with that language. But our bold, audacious goal, we really ended up, we had 30 days, so it wasn't that we got to go through a huge stakeholder input, but we really looked at, well, what are we doing? What is already in play that was in play before high-tech ever showed up, and so therefore is most likely to be in play after high-tech goes away? And the two areas we focused in on are foster children, and a lot of the work that Judge Nash is going to talk about really highlights part of why we chose that area, and the long-term post-acute care, because it really drives the care coordination piece, which drives the need for really moving information. And we highlighted the idea of a personal health record because we wanted to pull in the individual engagement piece, but I use that term lightly. And as Daniel has mentioned, we've been talking in kind of this community around the idea of an electronic care record for the foster child that includes these different components. So what does that need to look like? So that's been part of that. And to kind of close out outcomes, so really we're here because of the outcomes that we're trying to change. Health happens outside of the healthcare setting, but at the same time, we have to do things with our healthcare delivery system or it's going to break us financially. So we have to work on both parts of the process. And our human services really extend the influence of a provider's care. If there aren't services to go to after a person leaves the doctor's office, those doctors' recommendations are going to be very limited in terms of their actual implementation and impact. It can't be solved with a pill. Gosh darn, wish it could, but that doesn't necessarily do it. It is an important impact, though, on our quality of life and the way that we are able to live our lives. So not to diminish that, but just to keep it in perspective, especially when we're thinking about interoperability and health information exchange. What's the win? What's the sell? Why should we invest in this? And it's because the best way to lower our healthcare costs are to get connected to the things that are outside of our healthcare delivery. Personal opinion. Transitions happen. So do we chase the paper or do we follow the electrons? And what does that mean for the patient, which is us? So what will be the measurable outcomes? And I think this goes back to the things we see in this quality strategy, the triple aim. So improve care delivered, improve population health, who are we as a population and community, and decrease the cost. So that's what we're here for, and it's definitely been an adventure, and it will continue to be. So I look forward to continuing to work on this in the new role that I have and being part of this team. So thank you.
Well, good morning, everybody. My name is Mike Nash, and I'm the presiding judge of the Juvenile Court in Los Angeles County. And some people, I think that's kind of a unique privilege. Some people think it's a dubious privilege. But Los Angeles is a unique place. In Los Angeles County, as you probably know, we have a population of well over 10 million. When I think about the courts that I preside over, as presiding judge, I have 20 full-time dependency courts that deal with all the cases of abuse and neglect. And currently we have over 26,000 children under our court's jurisdiction because they've been abused or neglected by someone close to them. We also have 24 full-time delinquency courts, currently with about 20,000 youth on probation in Los Angeles County. And Last week I used to have 16 more courts, but due to budget cuts, those courts have been eliminated from our system, and we're attempting to adjust to that, but that's a discussion for another day. In my job as presiding judge, I work with all the system stakeholders. That includes lawyers who represent everybody and anybody that touches our system. We work with 81 school districts in Los Angeles County. The agencies that work in our courts include the Department of Children and Family Services, the County Probation Department, Department of Mental Health, Department of Health Services. Also, we work with numerous community providers and countless community advocates and others. So it can be a real mess at times. Now, I think I've been brought here today, to sort of give my perspective on the issues that you've been talking about. I know I'm preaching to the choir here, but I think it's important that you understand how this work that you've been talking about does impact us. Now, the role of a juvenile court judge is a unique role. In fact, we have a standard of administration in California that's called the unique role of a juvenile court judge. It's unique in that when you think about the traditional role of a juvenile court, or of a judge is someone who essentially calls balls and strikes in the courtroom, makes sure that the process works fairly for everybody in the courtroom, and ultimately makes decisions such as who did what to whom. We do that in the juvenile court, but our role goes beyond that. Congress, going back to 1980, and our state legislatures have given the juvenile courts an oversight function. That is an oversight function on how the system, be it the child welfare system or the juvenile justice system, is functioning for the people that are involved with that system. So among the things that we do is that we order services, we oversee the implementation of the services, we in effect evaluate the quantity, the quality, and the quantity of services that are provided to folks that come through our system. We also are expected in the unique role of the juvenile court judge to bring folks together to work on obtaining resources for the system and working on processes to improve the delivery of services to the system. I heard someone talk today earlier about someone ordered a bunch of lawyers in a room and told them to fix this. As a juvenile court judge, we do that. We have the ability and we're expected to bring folks together and lock them in a room. The only problem is that I'm locked in the room with them. The expectation is that when we lock ourselves in a room together, that we will identify a problem together, and that when we leave the room, we'll come out with some solution that will be better than where we started. It won't necessarily be perfect, but that's okay. But we'll be better than when we started. That's really all you can expect. But the important thing about all this, in order for us, for me and my colleagues as juvenile court judges to do what we do and to do it well, is that we need information. We need information that's accurate, that's up to date, and complete. And that is often a problem for us. Now, what I've been hearing about since today are really discussion of two issues. One is confidentiality and the other is technology. Let me just say this about confidentiality. It permeates my existence. I'm not going to say it's one of the banes of my existence, but I guess it is. It's something that we deal with every single day in virtually every issue that we deal with in the juvenile court. The question is, what can we share and with whom can we share it? Through my office in Los Angeles, we process thousands of requests annually for access to juvenile court records. And once again, the analysis is what can we share, and can we actually share it with the person or entity that's requesting the information. As some of you may know, I have been a proponent of open courts in the juvenile court context, and I have been accused of opening the courts. But that's not what I've done. All I've done is, once again, create a process to provide access to the courts for those who are entitled to access to the courts. But once again, get a lot of pushback on that sort of thing. You've heard from Larry Bolton earlier about some of the issues that we've had in education. Obviously, in the child welfare system, and really in the delinquency system as well, we're concerned with safety of the children. We're concerned with safety of the community. We're concerned, we want every young person that comes through our system to hopefully end up in some sort of a permanent setting, a home. And while we have these children and youth under our jurisdiction, we're concerned with their well-being. That means that we have to be concerned with their education. We have to know how they're doing in school. We have to know whether they're going to school. We have to know if they need special services from the schools. And then if they do need special services, then it's up to us to figure out how to work with the school districts to make sure that they get those services. And that, of course, all that involves, obtaining information, and it can be a problem, and it certainly was a problem in Los Angeles because of the way that FERPA was interpreted. I was told by the school districts that either we had to get the consent of the parents or we had to have a court order. I said, well, that's easy enough. I can issue a court order. And I, in fact, did issue a court order, which was a blanket court order that said for every child involved in the system, we're concerned with every child's well-being, and we need to know their educational progress, and therefore you have to give us the school records. And once again, got a lot of pushback on that, saying that, well, a blanket or a standing court order isn't really a court order. I said, well, what is it? Chopped liver? Ultimately, we worked it out. The court does have some powers, such as the power of contempt, and in fact, we had to use it. But once again, it worked. But that still hasn't solved the problem because, once again, what we're doing is we're getting information, and this gets to the technology issue. We're getting information by way of paper. Okay, and there's a process involved in getting stuff through paper that delays that process. And so we're hopefully, close to the point where we'll be able to transmit this information from the school district to the Department of Children and Family Services electronically, so they can inform the court about the child's education progress. And once again, what does the child need? What do we need to work on for that child to enhance their educational outcomes? So, confidentiality, it's a pain, but we can deal with it. Technology is another question altogether, and that's why I'm really excited about the work that's being done here, because I'm not sure what century that we're living in these days. And I'll give you another example before I sit down. In California, one of the things that our courts are required to do by law is we are required as judges to approve the administration of psychotropic medication for children under the court's jurisdiction. And that could be a difficult proposition because the last time I looked, there weren't too many psychiatrists or psychologists on the bench. I like to say that I'm the only psychiatrist that I'm on the court, but I'm just a psychiatrist for my colleagues. But you have to understand how the process works. It's done by paper. I have a doctor who fills out a form that the state has created, which is not a bad form, that is then transmitted to the Department of Children and Family Services, who then sends it to the social worker, sends a notice to the parents, and then sends it to the court. And we have to make a ruling on the medication, the use of the medication within 7 7 days, which is a very short turnaround. In the meantime, we have this thing called due process of law, so it has to go to the child's attorney, has to go to the parent's attorney, at least from a notice perspective. They have to have an opportunity to file an objection with the court. And also in Los Angeles, we're very fortunate in that we have the Department of Mental Health that evaluates all of these requests for medication. They tell us, based upon the form, okay, that's been submitted by the doctor, that the medication is appropriate for this child for the symptoms that have been described on the form. Once again, I have no indication that the doctor has had access to this child's complete history. Kids move all the time, get new doctors who prescribe new medications. The Department of Mental Health, when they do their evaluation, once again, they're doing it on paper. They're doing it based upon the paper that they received. They don't even have the court file. When it ultimately comes to me after 6 or 7 days and I have to rule on it like that, I have to make sure that even though I may not know anything about the drugs, we do, even though we get some training, I have to make sure that the information is accurate. I have to go through the court file and look at the previous request, the previous history of the child, and make sure all of this is consistent. It's a crazy way to do business. And obviously, when you think about it, it's fraught with danger. It's fraught with danger for the children, and that's not right. There has to be some sort of system that puts all this together so that those of us that are making these decisions can make these decisions in the best way possible, and we're missing that. And that's just one example of how technology or the lack thereof impacts us. At the end of the day, when you think about it, what the lack of appropriate technology does for us or doesn't do for us, or however you want to look at it, it impacts our ability to make timely decisions on behalf of the children and really even the parents that we're dealing with as well. And it also potentially impacts our ability to make the best decisions possible on behalf of these people. So I really commend the Stewards of Change for this work and the fact that you all come together to work on this, and hopefully at some point we'll recognize that we're in 2012 and that it's time that we started doing this, utilizing the technology that's available to help us do our jobs in the best way possible. Thank you.
Okay. Coolest thing about the next couple minutes, you got one slide to deal with. That's it. I'm really, really happy to be here for a couple of reasons. Number one, they let me out of the building. I'm with Children and Family Services with the State Department of Social Services, and I'm the inside guy. I'm the guy who handles the budget, the contracts, the HR stuff, the moving between program areas and feeding the directorate information that they need in order to make decisions, that sort of thing. The inside guy. My boss, Greg, is the outside guy. He's the one who deals with many of you on a national level, helps with making sure we keep our flow of goodwill communication in collaboration with our 58 county leaders in terms of human services delivery in the child welfare arena. And so together, I know, we're cat shepherds. We herd cats for a living. That's what we do. And as part of that, we just... It's really interesting to be here and to be with many of you who are sharing some of the same struggles and from different levels of government, different levels of advocacy, all of these different places where you come from. You're dealing with these common issues in terms of service integration. It's really exciting to hear and to see such a big group that are advocates for promoting integrated service delivery, coordination among different partners who are seeing the same people many different times for a lot of the similar reasons, and getting these folks to talk to each other in a way that brings services in a coordinated fashion to families to help them move from where they are now into a better place. One of the things that we're trying to do better is to take aggregate information from a number of different places and make that use it more effectively to make better decisions. Barbara Needell with UC Berkeley helps us with the outcome stuff. We have advocates who collect information on their own. We have counties who are collecting information on their own. Talk about herding cats, and as I talk about cats, I'm referring to counties, 58 of them. I'm talking about a wide, huge collection of advocates on everything from benefits receipt, on the TANF end, the in-home supportive services end, foster care, you name it. Private nonprofit philanthropy. We have those partners who have some specific service objectives, want to see us get to a place as a system together, and are often frustrated because all of the different really excellent ideas that you've heard about from San Diego, from Alameda, from Ventura, from all these local solutions to really important problems. We have, I imagine, Terry, Stewart Foundation and your colleagues in the other philanthropic organizations are perennially frustrated with us at our inability or our seeming inability to bring really good ideas to scale. And bringing anything to scale in California is tough work. It's tough work. Like I said, 58 counties, millions of folks. I mean, I'm just looking at the website this morning on caseloads in various areas. TANF caseload, there are 577,000 TANF families out there. When I came, I spent some time in local government as well. Worked for 2 counties, did some nonprofit work before I came to the state. We have in 2005, when I started with the state, there were 4 statewide automated welfare systems. 4. Now, as a county person coming to the state, I had no problem with that. I had no problem whatsoever. Well, 4 of them, well, you have to have, it's California. It's California. And the other thing is, well, the reason why there are 4 is because during the 70s and early 80s, the state had a shot at it, had a couple of shots at it, and really didn't get it right. And so guess what? If the state could do it and do it one shebang and get it right, it would have been done already. So guess what? Now you have 4 back in 2005. Now you have 3. We're moving to 2 pretty soon on the welfare side. But one of the statewide systems that, depending on who you are, you'll perhaps say that we got right was on child welfare. Our SACWA system is it's state of the art for 1989. And we're still working with a mainframe. You got to be sitting at your terminal, at your desk, connected by a line to that server over there in order to enter data, get data, do what you need to do. No interfaces with other systems in real time. The places where it falls short in terms of the federal expectation, in terms of the business need for case-carrying social workers out there is so severe that in 2012 that there are a number of external systems that folks have come up with at the local level just to solve today's problem. I mean, and when I say you may be thinking like a handful or whatever like that. No, we're talking hundreds. We did an external system survey a while back, and there's over 400. Just look, everything from an access database to full web portals that connect to this place and that place and the other place. And again, really good ideas. Little piece of information over here, little piece of information over there, smidgen here, tidbit over there. When I'm being asked for statewide information on a number of these programs. And so we're always struggling with how to take something to scale. Don Edwards is from Alameda County. And he came in 2 years ago, right around this time 2 years ago. He came into my office one day. He said, Kevin, I want to show you something. Sits down with his laptop, and you've probably seen the application before. It's a data warehouse that he and a vendor put together, along with an analytics application that will show associations between clients. I mean, you know what these applications do. Show a household with a boyfriend and a girlfriend. Who else is living in the household? Mom's living in the household. There's child care going into that household. There's 2 TANF cases in the household. Connect all of these things. The moms in IHSS, and in-home supportive services, recipient now. She used to be a provider. All that information, all the case information available in one spot. And you see associations between people. You see histories. You see the whole shebang. And you see an entire client, not just of the family, but everyone else that the family has touched in terms of identifier information, addresses, phone numbers, case numbers. Cool. What could you do with that? What could Barbara Needell do with that? My God. So I'm awestruck. I'm sitting there just, oh my God. Don gets up and walks away. You know, Don is cool. He got that little strut, you know. So yeah, you know, he blew me away. So yeah, he's walking away. He's real cool. He's at the elevator. We do business in an 18-story building. So I'm on the 17th floor. He's sitting at the elevator. I go running out to him and I say, Don, how much did that cost, man? He says, 1.3 million. In California, that's not even change. That's the lint speck in my pocket right now. Okay? So I'm thinking, I let him go. I'm just sitting there. I let him go. I couldn't. I had no words. Let him, a couple minutes. I'm sitting there at the elevator, and I go running down the stairs. Running. Okay, 18-story building. I go running down the stairs. Elevator wasn't fast enough to the 8th floor, and where my welfare to work partners are. And I say, hey, have you seen Alameda's application, this data warehouse and this analytics? You see, it does this, it does that, it does that. Yeah, I saw it. Well, why can't we bring that to scale? We have all of those. He's taking data from systems that we have immediate control of right now. We could work this today. 1 million, that's nothing, dude. We'll never get those folks to share that data. Never. Ever. That's what I said. Never, ever, ever. 2 years later, here I am. And here they are talking about, hey, we got to share data. Oh, my God. So Nick, Don, Terry, Barbara, California, the nation. You guys are, we're getting there. California's big and we slow, but we're getting there. We're getting there. So we want to be able to use data sharing for good decision making. We have this, and yes, we have on the child welfare, and we have a clunky system. Fine, we're looking to replace it. We were evaluating contracts for the new system in 2011. Okay, and then the May revision of the budget came through, and all of a sudden, I guess that's when we found out we were broke, I guess. I don't know. So we had to suspend that project. We're looking to, get back on the horse and try another approach that may cost a lot less money, which is great. But between now and then, we're going to have to make do with what we have, and we're going to have to find ways to get data into each other's hands to again encourage good decision making. The foster care use case that we were helping with Dr. Lynette Scott with. MOUs with our partners, Department of Education, our probation partners, the Stewards of Change, Daniel and his crew. They are on the phone with me or in my building at least once a month, at least, talking about different ideas. I mean, this electronic care record that we hope Judge Nash will have access to soon. I got to find my little piece of it is relatively small. Find a little seed money, and again, herd the cats. Make sure everybody is kind of walking in the same direction. I was telling Judge Nash before we got started with this session, you have a problem, but do the county welfare agencies know we have a problem? I mean, we get you the court report form. We send you reports every single month on a kid. What's going on? What information do you need access to that you don't have? Well, that's great, but the decision had to be made 6 months ago. I get that. So we're working with you. We're thinking that this electronic care record, if we can ever get something off the ground on a statewide level, we'll be able to serve children more effectively. My job again is to be a help and not a hindrance. Herd all the cats. Get my what do you call that thing? You call it a staff. Bring the staff. Bring some resources. Make sure that we're a help and not a hindrance. That's what we're trying to do. That's what we hope we bring to the table. And I'm really excited that we can work together. And I'm really looking for lessons from all of you who have been there and back to help us to not fall into some of the pitfalls that perhaps you've experienced in your journey as well. Thanks.
So I'm not from California, but I did go to school there for a little bit, so maybe that's why I'm allowed to speak today. I'm honored to I guess I'm to clean a batter or something. Did I leave my glasses?
There you go.
And it's a real honor to be speaking to so many people here who have done so amazing things. I think I'll be starting off by giving a bit of this perspective from informatics. Just wanted to. The word informatics is a word that most people hate, especially informaticians, because we don't know most of us don't know how to describe what it is that we do. In fact, an article is coming out just today in AMIA, the American Journal of the American Medical Informatics Association, defining the competencies. It goes on for about 30 pages. So let me give you the soundbite. So health IT is what you can do with IT. Informatics is what you should do with IT. And when you start thinking about the should, you start thinking, well, we know all the cans, and we know we shouldn't be negative, we know we should be positive and all that sort of stuff. But sometimes we have to view these things as interventions that have benefits, but they also have costs. And informaticians have been whining for 30 years, use the HRs, use the HRs, use the HRs. Thank God, ONC comes along and says, use the HRs, and then we start saying, no, don't use them. We didn't mean what we say. Because we're very sensitive to harm. And we also know the harms that come from EHRs, and especially when you start using EHR data outside of the original source, we start getting very nervous. So humans. Now, I've been getting a lot of education about human services through involvement with the NISIA project and APL and Daniel and the group here. And I'm certainly no expert in that way. But anytime you start using data outside of where it started from, you have to start getting very nervous. And even though medicine is only 5%, and the evil doctors, we know, and I know all that. But at the same time, the medical record is a source of truth for medical facts about a patient. So we have to be careful about what do we mean, what do the data mean. So I wanted to point. I wanted to get. I want to start with that kind of notion. The idea of using data outside where it comes from in HIE. Human Services is kind of a client of the health informatics exchanges, which is great. So maybe it's just, if the HIE folks are thinking about this, well, it's just another HIE client, and it'll be easy. But again, we have to recognize that Human Services is a different environment and different use case. Now, we've been talking over the last 3 days recurrently about a kind of a high level and a low level about all this health IT stuff. When I teach informatics, funded, I'm happy to say, by ONC, we talk about the line between what you want to accomplish and how you want to accomplish it. And that line, so we actually talk in class, is this an above-the-line issue or a below-the-line issue? So business process is above the line. The interoperability is really below the line. The web is below the line. The notion of an electronic care record is somewhere at the line. Informaticians tend to live at the line. So one take-home is listen to people you're talking to. Are they talking above the line or below the line inappropriately? So none of the people in Kevin's office should be talking about using technology words. Even the word data warehouse gets me nervous because not everybody knows what that means. On the other hand, you don't want your computer programmer talking about words like diagnosis and treatment because they don't know what the heck they're talking about. So you got to be very careful about this language business. So we heard about right information for the right person at the right place in the right time, et cetera. We heard it from Izzy yesterday. We heard it today. But if the person who's getting the information is not valued by the institution, so in EHRs, nurses are big users of information, but nursing systems are not really tailored to nurses, and very often the vendors really don't pay attention to who the nurse is because they're focusing on selling it to the administration. So one concern with an ECR record or a human services record is that the frontline worker who really needs the decision support, the system may not be designed for that person. And if you ask how much public health workstations are there with decision support for frontline workers in public health, I think the answer is one. I've heard from San Diego, maybe one. And with 10 years of effort in building biosurveillance, even the Essence system is built kind of for an epidemiologist, but that's kind of about it. So we have to value the people we're working for, and we're not always, so that's something, especially people in human services should be sensitive to that, but sometimes the budget and the processes do not help you with that. We've heard a lot so now going below the line, we've heard that technology isn't a barrier anymore. After all, we have the web, we have connectivity, except in California, we don't have mainframes anymore. Well, just last week in New England Journal of Medicine, there's an article by two top informaticians. Basically, how come with all this Google stuff and all this internet stuff, how come we're using 20 to 40-year-old technologies in the EHRs, right? And why aren't things happening better? And I would commend you to that article. But one issue is that it's not just that technology has changed its name. Technology is no longer the electrons. Technology is no longer the wire, except, of course, in California. But it's the meaning of the data. And what is a semantic integrity as data goes from one system to another system to another system to another system. And by the time you're playing telephone, but now we're playing computers. At many hospitals, many academic centers around the country are motivated by meaningful use, to be honest. We're dumping everything we've had and built over the last 20 years, and we're buying one vendor's system because we don't trust interoperability. We're sick and tired of killing ourselves trying to make systems talk to each other. We're tired that if you put an allergy in your outpatient center, that allergy does not come out with the same integrity in the inpatient system. You have to ask again, and even though we're supposed to write once, use many, it doesn't work. It doesn't quite work. We have a lot of standards, and they just don't work enough that you can trust it entirely. And if you're not going to trust it entirely when you're talking about lives being saved, et cetera, well, that's a big issue. So the integrity of the data getting from point A to point B to point C is a huge issue for us, which brings up this whole notion that even in HIEs, how do we trust data? Why should we trust data? Now, in HIEs, it really is clinician talking to clinician. And when a clinician sees a medical record, they know what to take seriously, what not to take this seriously. We know when the story makes sense, we know when the story doesn't make sense, we know what to ignore, we know what to look for, et cetera. But we're very worried that other people looking into the medical record will actually take at face value what they're seeing without the ability to say, wait a minute, that doesn't make sense. And there's a whole community there are a couple of communities I hope you'll know about. First, funded by ONC, there's the SHARP Emerge community. I don't know if you're familiar with that, looking at secondary use of EHR data, headquartered really at the Mayo Clinic. There's also from the NIH, I think a federal agency not used to working with, is the Clinical and Translational Science Awards effort. I won't go into all what's involved there, but one part of that is there is an informatics community across all the academic health centers, mainly all the top research centers in the country. And we've worked mightily to understand and to promote information sharing, communication, transmission, and all the stuff that you were all talking about. We'll be publishing a paper. Academy Health asked us to put together a paper on the do's and don'ts of secondary use of EHR data, what to and how to be scared and how to be very scared, issues that come up, data quality. As I told you, you don't take the data at face value. We know the data are gamed. We know that the semantics of data are defined by the workflow. Who entered the data and when did they enter it? And that's, again, clinicians understand how not to take it seriously, but somebody on the outside may not understand that this diagnosis of an MI, of a myocardial infarction, was presumptive, but they weren't allowed to say presumptive because the system didn't let it say it. So they said myocardial infarction, and now it goes out that the patient just had a heart attack, whereas they really had gas or something like that, right? So we worry about that. Currency of the data. We heard Judge Nash wants to know what drugs are you on, what drugs are you prescribed for, and of course, is it last month's prescription, 2 months ago, all that. It's a real issue. A real subtle issue that is not discussed almost at all is uncertainty. And we say that medical data are uncertain, but we don't really have, and none of our systems let us say how we are uncertain about the data. So what? We're uncertain. The patient comes and says something. Did I hear it accurately? Did they actually mean what they said? Did what they say mean what they meant to say? Did I record it, what I heard? Did I collect all the data that goes along with what they had? If somebody says, I have chest pain, there are about 18 other things I should be asking for. Did I ask for those other 18 things? Is the absence of data mean a negative? No. Right? So then did I think about all the diagnoses that should go along with that data? Did I think about all the treatments that go along with that data? Did I write the treatments? Did I record the diagnosis I'm thinking about? Did I write the treatments? Did I transmit it to the pharmacy? Was it picked up? Did the patient take it? Did they take it in the right way? All those are uncertainties. Now, are those? Am I talking about the perfect getting in? The perfect getting in the way of the good? No, because we know that we need all this stuff, and we need to get at it. We need to integrate it and to use it. But I just don't want to leave you say that the problem has been solved. I mean, when I tell people about when I'm involved here, I say, now that we've solved interoperability among electronic health records, it's time to move on to human services. And everybody laughs because we know we haven't solved it at all. And so it's just beginning. So I just want to, so as you think about the electronic care record, I hope that you and we think seriously that the EHR that model is not I don't even know if it's the right model. It is a model. It should inform what an ECR is going to be. I hope we learn from the mistakes of the EHR, and I hope we learn to design the ECR for the real users and the effect it's going to make. And just a couple of points in closing. One is I kind of hear workforce issues. In other words, we don't have a lot of people who know the informatics in human services, and so you should be treasured. But also, what's a professional home? Is this the right place for it? How do you interact with other professional societies? How do you advocate in those professional societies, whether it be APHA or APSHA or AMI or whatever? I think we're developing a community and a profession that hasn't existed yet. So in the last minute, I just want to thank, I'm thrilled to be here and to be talking to you. And I think we, as a close-up speaker, I just think we ought to thank Daniel and all Stewards of Change for putting together this wonderful meeting and getting all of us from different perspectives to talking to each other. So.
So I want to thank our speakers this morning. With this panel itself could probably have taken a half a day in terms of the content of it. We wanted to expose you to the idea of taking the conceptual into a practical application, albeit with lots of concerns and considerations about making sure we get it right. We are, from a scheduling perspective, just a little bit behind where we wanted to be, but I wanted to just open it for a couple of minutes for if there's any burning questions out there.
Harold, I thought your discussion at the end was fascinating and thought-provoking. I actually hadn't heard that perspective, maybe living in the silo that I do, about related to everything.
Yeah.
I can keep talking.
Steel doors will come down and the building will collapse.
Scotty, beam me up, please.
Assume a position.
Okay, really? All right. So anyway, is this just you, a voice crying in the wilderness, or is there a sort of a national conversation that the rest of us are missing?
About the potential harm, about the concern of the harming stuff, it absolutely is part of the national debate. There are people whose careers are made on identifying errors in medical care and the EHR. There's a sub-community that's really radical, really obstructive and loud, pointing out how this is an intervention that has not been evaluated, or what we should tensions about that. But certainly the potential for any policy change is an intervention, and all interventions have benefits and burdens. And we just have to, and all I'm saying is we have to be honest about them.
If I can add to that, I would also just say that part of the discussion is clarifying where these are issues unique to electronic health records as opposed to medical data in any format that it resides, and that's very important because that semantic interoperability happens as we talk to each other, or lack thereof, not just when we send system to system. So I just want to identify that having a set of data elements and a data dictionary and looking at semantic interoperability precedes perhaps the input of that information into technology. And we need to make sure that we're talking about the same thing. I don't think my doctor understands what I'm talking about before he even starts to type it. So,
but Watson will solve that.
What?
Watson will solve it.
Watson will solve it, right? So I just wanted to note where we have issues that are actually outside of technology and then perhaps could be exacerbated once ingested into technology versus things that are inherent to technology. And
compared to what? I mean,
right, compared to what? Right.
Exactly. If we're better than some other thing, that's fantastic. We just have to be honest.
Yeah.
Don.
So, Judge Nash, I have been a huge fan of yours since 2009. And it's been your work and your decisions that have helped Alameda build the system that Kevin was talking about earlier. What I find really interesting, though, is that MasterCharge and Visa and American Express know more about me than me. And the only other entity that has even more information than that is the government. yet we're unable to get our acts together to share common information. So my question, and it gets to some of the things that Linette has said as well, is how do we pull all of this together so that we can get information about a child who goes to school, maybe, who has an appointment at the behavioral health department or the public health department, who has a foster parent or three. How do we, as an organization, pull all of that information together and make it happen?
25 words.
I left my magic wand at home. That's the $64 question that we've been dealing with forever. We seem to get a lot of this piecemeal, sometimes on an as-needed basis, whereas we really need it on a regular basis. So I don't know where. Yeah. Daniel's going to answer that.
I'm going to answer that question. I think we're on that journey. I think there's examples. We've heard a few in this conference. I think there's people. I think you're leading the charge in a lot of ways. So I know sometimes that's scary if one thinks one's leading the charge and how far you are behind. But and I'm not saying that specifically you do, Don. But there's a lot of folks. Uma's doing great work in Montgomery County, and Nick is doing great work there, and there's stuff in Allegheny. There's stuff all around the country. The problem is, in my mind, is that there is not a community that is really encompassing and bringing together all of those examples. Because we did a conference in California in October, and we brought together a bunch of counties, and you guys didn't know what, 100 miles down the road what was going on. And there's not a mechanism, it's not an indictment, it's just simply there's no interoperability office, right? There is no place where that stuff sits. And what we've been trying to do in the community of people who've been here have been trying to ring that bell to say, that's a really vital function because we could really jumpstart that. The work that you've done and the time you've invested in this room, the people who have gone out of their way and pushed the envelope to do and innovate and create is mind-boggling, and yet it's locked in our brains, or maybe we've been able to bring people together, and other folks have been able to bring people together. I know Anita and APHSA has been doing that, and other organizations have been doing that, but we don't have a place. We don't have an organization or even an affiliation that says, almost like what Harold was saying, a human services informatics group or an interoperability group. And part of our hope and prayer is that because we have some federal folks in the room and some state folks and judges and folks, we can bring that bell to the point of saying, let's put this together and let's stop recreating the wheel. Let's make that information available so it's readily transferable the same way the HIE's information from the innovation grants and the early adopter grants and innovation things are out there. People can go pull them down from these large access points. We need that for human services. There is so much good work going on around this country, and yet we don't know about it, we can't see it, we can't access it. And I would think that would be if I could ask one thing, which I will in the next session, we'll put on our action plan, is to put some of that lint, Kevin, some of that lint from your pocket. We'll put a little of that lint out there and maybe try to get this thing going, because I think it will be a virtuous cycle, and quickly adapt. And let's make sure we don't continue to repeat the stuff that we've screwed up on, and let's make sure that stuff is available and people are not hurt as a result of sharing their failures or their less than perfect examples with that.